Okay, so any questions?
I've got lots of questions.
Okay, let's start with you.
Yeah, maybe I'll ask first Dr. Fuster. You pointed out in your study that 10% of people had regression. I want to be in that group. To get in that group, 10%.
Actually, we are now getting the data, and if you want regression, take the drugs that you have to take. And this is an issue that I have for Dr. Stone, too. I mean, it's easy to revascularize small lesions, but I think the best revascularization is medical therapy. This is my view. And actually, this is what we are finding in PESA. Now that we have a longer follow-up, we have more regression than 10% I presented here, it's 25%. And in fact, that's the better treated people. So I just want to emphasize that we have a disease that we can do a lot by treating medically. And I don't debate what you said, but I just want to emphasize that we are missing a situation. And let me tell you more about the FREEDOM trial. You see the adherence to medication in a diabetic patient with significant angina, the adherence to medications that their patients were supposed to take was 30%. And this is what led us to think about polypills. And that is we have a huge problem here. You might revascularize, but I'm not entirely sure is the way we should be acting. Anyways, it's just a comment to what you ask.
So maybe I'll respond because I don't think drugs and revascularization are competitive. I mean, as I mentioned, atherosclerosis is global, it's systemic, and there's no doubt that that's got to be the foundation to reduce the development and progression of atherosclerosis. I think when you get a well-formed high-risk plaque, that's a big, bulky plaque, then it may be too late for revascularization to have an effect. And so in all of those studies, Prospect 1, Prospect 2, those patients were really treated well. A lot of them are on 4 or 5 drugs. They're on high-dose statins, all in Prospect 2, and they're still having events when they have 2 or more high-risk features. And Jagged showed other data with abnormal wall stress, et cetera. So again, the background for 95% of patients is going to be medical therapy, but if patients have gone too far because they were not compliant or they had years of abuse, et cetera, so we get them to that point, they presented with an acute coronary syndrome, they have other severe plaques, then revascularization may be useful for those individual lesions.
I want to tell you another thing, though. Some of the studies that you presented, the endpoints was just revascularization. I say this because all of us, when we talk about endpoints, we try to think about heart attacks, sudden death, and that's not the case. In fact, at least 2 or 3 of the studies that you presented, including your original study, the endpoint was actually very close to not significant, but was revascularization alone. So I just want to emphasize that not to really debate what you said, but I think we should still think about a lot. What endpoint are you talking about and how the patient is treated medically?
I think just adding to that and adding to Gregg's point also, if you look at the Yellow 3 study, in the Yellow 3 study, there were 20% of the people where we demonstrated a significant decrease in their LDL cholesterol, but the plaque size did not change. Right? So the possibility was that other lesions probably in the body must have been responding, but as you said, that some which have gone far are out too far, those are the ones we need to take care of. Now, what exactly and how exactly can we pick them up? So there were some very decent suggestions from Yellow 2 and now in Yellow 3. So in Yellow 3, when we looked at their transcriptomics, we found out that there was a distinct group of people which will not respond in terms of the reduction of their yellow or in terms of the fibrous cap thickness increase in those cases, distinct difference in the transcriptomics. Now, with the Yellow 3, we are hoping that we would be able to have a differential expression and we will be able to identify those who are likely to respond to statins, who are likely to respond to PCSK9 inhibition, and who are not likely to respond to either of them. So there could be possibilities where we could go and add on the personalized stuff on top of what exactly we are doing. But essentially, in most of the cases, we should be able to do what Dr. Fuster was suggesting. So I've got some more questions here now coming up. So people have gotten the hang of QR codes here. Yeah, they are really profusely coming now. Dr. Fuster's question was, oh, sorry. If you want to reduce it, then the first thing is that go very early. I know why when people ask that, what can I do now? So we have to say we are too late. No. We're going to do it now. Right? Is that correct or no? No. Right.
No, I agree, we should alleviate you.
I want to reduce it, but
You are too late. That's your problem.
Well, how long does it take to see regression of LDL less than 55 over a period of 1 year or 3 years when treating regression disease? Dr. Fuster, would you like to take that?
Dr. Stone.
Dr. Stone, okay.
Oh, well, imaging studies have shown that within 6 months, I mean, you'll see regression.
Absolutely.
So, I mean, it can be relatively quick. You see, the greatest reduction you'll see actually is in reduced amount of lipid and thickening of the fibrous cap. You don't see much changes in plaque volume. I mean, over 1 or 2 years, you might see a 1 to 3% reduction in plaque volume, but you see major changes in the morphologic high-risk plaque characteristics.
Yeah, I mean, Dr. Kinney's presentation back in the ACC this year, there was a more than 50% increase in the fibrous cap thickness within 3 months' time. Actually, that was the 3 months. 6 months' time. You're right, exactly. And the LDL reduction and the CT angiography study, we had demonstrated that even a small reduction in the LDL by looking at the CT angiography in 9 months' time, we were able to significantly reduce the low attenuation plaque volume. So the second question, reality in outpatient clinics, PCPs are not well trained, informed by ACP. Use of statin, SGLT2 inhibitors or GLP-1 receptor agonists, and resist regarding the treatment of LDL HbA1c. I've not gotten the question right. Who was it? I mean, would you come up and ask the question? Yeah.
Well, all the teaching is wonderful, but when we have clinics, the cardiologist prescribing medicine, primary care physician are the ultimate voice, especially when diabetic medication, which have cardiac use, we are not allowed to start and they will fix. And they are the referring sources. So we have a compromise, and there are many patients who will be on minimum dose of very not so strong statin. So we have to live with all this. And hemoglobin A1C, Dr. Fuster 5.7 or something. Even at 6.2, they do not want to. They just say, well, you're pre-diabetic, just too tired. And it is good to talk, but in reality, there are a lot of people are not getting sick, and we cannot do it. Because the primary care physicians do not have the latest, and they are not fully aware of. And they are really the force. We are.
He's going to cheat.
Oh, excuse me, you go. Just a clarification, when you say "we," are you talking about cardiologists?
Right.
Why not? Why are you inhibited from changing the prescription and writing a letter to the primary care physician? Is that not acceptable?
They do not, in reality, they do not want all of that. They are not, the atmosphere is different. They are in charge and they don't like us telling them what to do. It is the reality because we are,
Yeah.
at least in Bronx. I love Bronx. It is true.
I was afraid of that when we were planning the Courage trial. We were worried about the conflict between the investigators following an algorithm and go to high-intensity statin versus how the primary care physicians would respond. Things have changed so much. I think that, I think that the primary care physicians are overwhelmed and would like the help and the direction and trust the cardiologist. At least that's my experience. I don't know if others.
Okay.
Bronx it is
Yeah.
It varies,
Yeah.
it varies a lot by location, and I'm I'm lucky because there is many cardiologists around and I can use it, but if someone does not have that luxury of specialists, that's a different story. So I think it varies a lot.
Okay. So there is a question for Gregg. Do you think physiology co-registration will play an important role in assessing the residual ischemia post-PCI?
I'm sorry, will residual physiology post-PCI become important? I think in selected cases it is. The question really is, if we do it routinely and systematically, are we always going to be able to identify problems, and are we going to be able to routinely impact them enough by redilating the stent or treating these untreated lesions, et cetera, to be able to demonstrate in a 2,000 or 3,000 patient randomized trial that we can overall improve outcomes. That's why we're running the trial. But I have no doubt that in individual cases, like I showed you, you see a 50, 60%, stenosis that's physiologically very severe in a patient with chest pain. That should have been identified and treated up front. So I do think that, routine post-PCI physiology is going to be helpful in selected cases. And we have to, even today, use a little bit intuition, but clinical experience to know which cases those are.
Thank you. And the next question is by Dr. Gidwani. Is epigenetic age just a new way of looking at traditional Framingham risk factors? Dr. Fuster.
Epigenetic is one of the hottest issues today, as you know. And just to give you a sense, in JACC, we have 8 articles coming in, which will be chronological age versus biological age, coming in about January of this coming year. Is a very hot subject. I think that we will be absolutely looking at methylation as one of the key aspects when we want to know, this time is biological age, if there is any testing that is being done and is becoming almost a standard, is methylation of the patient. And that is higher is the methylation, shorter is the biological life.
Right.
And less methylation is prolongation of life. So this is a very hot subject. I think the question is the technology has to be standardized because, for example, we use 8 variables. That is DNA genetic alteration. Some people with artificial intelligence are beginning to use 15, 20, and so forth. So this has to be standardized. But this is very hot. I mean, I would like that my chronological age, the biological should be much shorter. And I think the type of testing that is evolving is in this direction, and it's very exciting.
And there is another one on the similar lines. The methylation, apart from the genetics, does homocysteine play a role in coronary artery disease?
No, sorry. Thank you. I'm sorry I didn't hear the last part of the question. We are not entirely sure. Actually, the sense, and this is all hypothetical, and that is, the hypothesis is that methylation in the bone marrow makes inflammation to be very aggressive. And when we talk about inflammation being important in coronary disease, this is a super inflammation, much more than what you need as a defense mechanism. I think this is important because CHIP, for example, is completely the opposite. You don't have the defense mechanism that you have because there is this mutation of the genes that defend you.
Right.
Methylation, the DNA is the opposite. It enhances the inflammation, at least this is what we see in PESA. And therefore, this is the case that you can say there is too much inflammation that may lead to coronary disease. So are 2 opposed mechanisms that are completely new, but both appear to be important.
Thank you. David?
If I could just ask Dr. Fuster, do you think that there's a future for inhibitors of DNA methylation?
No question about it. Treat your cholesterol, treat your smoking, do exercise. This is the first thing we are learning about methylation. It's much more than that. But one of the things that we are learning is the risk factors have an impact on that. So I still would go into, stage 0. But there are many other factors that have to be discovered on the methylation. What really leads to methylation? There are a number of disease entities that are involved other than risk factors. So it's complex, but the identification of methylation is important. And maybe what you are saying, maybe specific pharmacological agents that might prevent the methylation, and other than the triggers, original triggers.
The next question is for for David. If a patient has an LDL greater than 190 with a calcium score of 0, treat, not to treat, when to repeat calcium?
LDL greater than 190, calcium score 0. And I think, so what the guidelines say is if the LDL is greater than 190, treat anyway. If this is somebody who's 80 years old, I think they've already shown that they're not going to get atherosclerosis. So I think age is related and other risk factors, but it's hard. In a patient who refuses, I think that it's reasonable to withhold and repeat a coronary calcium scan in a few years. But I would tend to treat anyway because of the likelihood of developing atherosclerosis. I think age has a lot to do with it.
And
Yes, your question. Excuse me, somebody.
I'm sorry, how young would we treat that? I mean, age old one, I understand, but young?
The younger the patient, the more likely I would treat. A younger patient is less likely to have calcified atherosclerosis. So you can miss a lot of atherosclerosis in a younger patient. How do you define young? Well, certainly less than 40. But if somebody's 50 and they have a calcium score of 0, I would treat.
Yeah,
now I know who the anonymous question person is. Anyway, okay. Another question is to your figure that you had shown, David, with the calcium in the patient. Remember the calcium scan? And the question is being asked is whether it's a primary prevention or a secondary prevention, which is what you had asked.
If that was a question, I think it's secondary prevention. Some very politically astute people will call it 1.5, but I think it's secondary prevention, especially if the score is 300 or greater. Matt Budoff and others have shown that a score of 300 or greater is a coronary disease equivalent in terms of clinical coronary disease.
Can I make a comment about calcification that fits with the question? In PESA, we use calcification on everybody, 4,000 people, as we did in the bioimage, 6,000 people. And we learned something interesting that you already mentioned, and that is, in the young people, you may have a lot of inflammation, but there's no calcification yet. So you are in big trouble with a calcium score of 0. So at young age, the calcium score can be very, because it takes time for the healing phenomena. But the second issue is, I would never repeat a calcium score because the chances of you being wrong are high. If you give statins, it's going to go up because there is more healing, more calcification. So the interpretation of a calcium score at older age is very troublesome. You do it once and it's enough, and then you work from there. And in younger people, it's troublesome too.
Unless the calcium score is 0.
0, yeah. Yep.
So
And
can I ask David a follow-up question? So, David, a lot of patients don't want to take pills for 40 or 50 years. So you've got a 30-year-old and their cholesterol is 190, and they say, there's never been any heart disease in my family. Okay, and you do a calcium score and it's 0, but that doesn't mean anything. So can you follow that patient with CTA as opposed to calcium scores? Maybe every 1 year, 3 year, 5 years, do a CTA to see if they're actually developing atherosclerosis? And last question is, should you also be measuring CRP and looking for background inflammation on top of LDL to help inform your decision?
Before I forget, I always check an Lp(a) in patients with strong family history or high LDL. And you said cholesterol of 190, you meant LDL cholesterol of 190. And what I do in practice, because getting a CT angiogram approved by insurance is not going to happen unless I have access to a relatively inexpensive, and I would say a few $100s for a CT angiogram. I would follow in somebody who refuses a statin, I would follow the coronary calcium scan until it becomes positive, and then just mandate that the patient be treated. But a CT angiogram would be a much better way to pick up non-calcified plaque. I mean, it's clearly a better way. Or Dr. Fuster is using ultrasound, and that would be an alternative.
It's somebody with the name of DLB says, I have a question for Kathy. So who's DLB? Oh, okay. So you have a question for Kathy. Okay. Yeah.
It was too much to type. It was pretty much you gave, Kathy. I think every healthcare system, especially academic ones, are struggling financially, tough post-COVID. As you know, we're going down costs. One thing I totally understand is, reimbursement, everything is going down. The aging population in our per capita Medicare expenditure is actually being pretty flat. Why is it that that isn't getting more credit?
It's a really good question, and I don't have all of the exact data that was in that article, but I believe it was the Part A that was flat, and Part B, because of all the shift to outpatient, is actually escalated, if I recall that article correctly. And that's what we need to watch. Part B, which is where all of our professional stuff is, and Part D, of course, where all of our medications are. And that is way up.
Do you think the Inflation Reduction Act will help at all in drug cost culture?
Well, it's interesting, but since you bring it up, just coming across the wires is a Politico, which is the big arm in Washington. The bills passed both the House and the Senate on site neutrality, and they're tagging it into that bill. So it is kind of a scary moment, honestly, right now, because I think the timing is right. I hadn't realized they were going to slide site neutrality into that, so I'll leave it to your decision. Personally, it's not going to be good for hospitals, and it's not going to be good for physicians. It will be good for Medicare, and it will be good for patients. There's no doubt about that. But our incentives are not aligned.
Kathy, couple more for you. There's a significant rise in Medicare Advantage plans versus the pure Medicare, which has lower payments to the providers. So what can be done about it?
Yeah, that's a great question. And what's I guess cool was the word I was going to say. The provider reimbursement is the same. It's the technical component. It's the DRG component. It's what it costs to do the nuclear or the CT. It's the technical issue that is dramatically different. But the professional fee doesn't matter. You can do a cath, honestly, in your garage if it was approved, and that professional fee stays exactly the same.
Another one for you that you discussed about all these external and environmental forces. How do we prepare the trainees?
A topic near and dear to my heart. I've got program directors in here. Please train them, because you send them to me when you're all done, and they don't have a clue what's going on out there in the world. And it makes it really, really hard when they come out of the academic world and they come into the world of community-based cardiology, and everything from coding and documentation to having to see a heavy clinic load and read echoes and read CTs and read MRs all in one day becomes extraordinarily hard for them. So whenever I have a chance to talk to the program directors, I plead, and our fellows, if I've got fellows in the audience, please come to the summit. We do the ACC summit every February, where some of these non-clinical competencies are taught. Look at the Practice Made Perfect podcasts that are on the website. Use the FIT section, because those are the things, you will do great training clinically, but our world is much more complex now, so it's a passion of mine. So please, anything we can do to help, please let us know. There is now a FIT, specifically a FIT program between Wharton and MedAxiom. The very first cohort just opened, and it's strictly for the FIT. So to really start at the basics of how all this works, which again, I don't know how it'll go because it's our very first one, but I'm very excited about it, as you can tell.
Thank you. So I have three quick questions. One for Gregg on role of intravascular imaging in Manoka.
Yeah, so quick answer, as I mentioned, I do think it's useful to identify, angiographically indistinct plaques. You got to be guided by something, so you go after the 20, 30% irregularities, and at least half the time you will find something abnormal. And we're also getting better now, I didn't get to talk about it, but with certain types of physiology to look at the microcirculatory resistance, where we can diagnose microvascular disease. And then finally, there's provocative testing for vasospasm. So we do have different ways to look for clinically indistinct causes of ACS.
For David, what level of calcium as a cutoff for starting aspirin?
Oh, that's a really good question. There's no clinical trial evidence, and modeling exercises suggest a calcium score greater than 100.
Last question for Dr. Fuster. What age should we start screening for coronary artery disease?
That's a good question, but I will tell you the guidelines are moving into age 20. But particularly because the whole issue of starting all the data from cardiac, the data from subclinical disease and so forth, is going to take, I would say, 2 or 3 years, but it's going to be at age 20, not at age 40.
Thank you, and please give a loud applause. Thank you.